Good afternoon, everyone. The topic for today is blunt aortic injury. Um, have a couple of cases of aortic transections which we did recently. One penetrating aortic ulcer case, and then we'll talk about blunt aortic injury, some mechanism of injury, pathophysiology, and imaging, and management by thoracic endovascular stent graft. We'll talk about the imaging modality for blunt aortic trauma, and we'll go briefly on the procedural steps of the TVAR as well. So this is a first case. She's a 45-year-old female. She presented to our hospital status post motorcycle versus motor vehicle head-on collision. She was ejected 40 to 50 feet, and she had loss of consciousness at the field. Other complaints were some wrist drop and elbow pain. She was hemodynamically stable in the ER with blood pressure of 124 by 80. This was the initial chest X-ray that was done with the concern of widened mediastinum. On the AP view, if it's the width is greater than 8 centimeter, they call it as widened mediastinum. With the concern of, with the mechanism of injury, high-speed motor vehicle collision, rapid deceleration, ejection, as well as concern for mediastinal widening. A CT scan was obtained in the ER. So this is an axial CT scan demonstrating left subclavian artery, left carotid, and innominate. Coming down, the scan arch coming down to the descending aorta. You see some contour abnormality of the descending aorta with the aortic transection beyond the left subclavian artery at the level of isthmus ligamentum arteriosum, where usually the injury happens. Coming down, looks like a pseudoaneurysm at this level. And this is the descending aorta that looks good with no contour abnormality. This is sagittal view demonstrating the left subclavian artery. Aortic injury distal to the subclavian artery with pseudoaneurysm. This is another view, subclavian artery, aortic injury with the pseudoaneurysm, distal descending aorta. The contour looks okay, no intimal flaps. So this patient was hemodynamically stable, good pulses, equal pulses in all the extremities. Initial plan was blood pressure control, which we did. Blood pressure was maintained around 100, 110, heart rate around 60 to 70s. We used esmolol drip. She had constant fevers, which she had other multiple injuries. She had pelvic fracture, lower extremity fractures as well, open knee. So orthopedics were managing those other injuries. She had constant fever. The concern was if we do TVAR on her, there's a potential for the stent graft can get infected. So we did pan culture. We started the patient on antibiotics as the patient was hemodynamically stable. So we waited for 2 days and we rescanned her. The injury looked a little bit worrisome on the falling scan. So we elected to perform a thoracic stent graft to exclude this transection. So basic procedural steps. We did this under general anesthesia. She was already intubated. did a percutaneous exclusion of the aortic injury. We obtained a right common femoral artery access with a micropuncture needle, and then a micropuncture sheath, 4 French sheath was placed. Then we placed an angle glide wire, and then we placed a 6 French sheath. Following that, we placed 2 close, that's the pre-close closure devices, one at 10 o'clock position and one at 2 o'clock position. Because the stent graft goes through a bigger sheath, 22 French sheath, but did not want to do a cut down. The access vessel was fine. It was looked good on the ultrasound, minimal calcification. So we elected to proceed with the per-close closure device. So once we did the per-close closure device, then we placed 8 French sheath. Then we placed the angle glide wire all the way up to the arch. Then wire exchange was performed, and a stiff Lunderquist wire was placed, and 22 French sheath was placed on the stiffer wire. So this is the arch angiogram. You can see a flush pigtail catheter in the arch, demonstrating this is the ascending aorta, nominate, left common carotid, left subclavian, injury distal to the left subclavian. You can see the pseudoaneurysm here. So we elected to perform place 10 centimeter stent graft. This excluded the injury. As you can see on this completion angiogram, innominate left carotid, left subclavian. The graft is right just distal to the subclavian. This graft does have some open struts at the beginning of the stent graft, and the fabric starts right here. So the injury is excluded. We did IVUS before the case, and just to confirm our landmarks and where exactly we're going to land the stent graft. So after deployment of the stent graft, we did not post-dilate this as sometimes we do it for aortic dissection. We usually post-dilate the stent graft, but for transection, because the aorta is already has the injury, so you do not want to create more injury. So we elected not to perform any post-dilatation of the stent, and we had good flow through the stent. After deployment, then the common femoral artery was closed with the already pre-deployed per-close closure system with good hemostasis. The incision size was less than 1 centimeter in this case, and procedure time was around 55 minutes. 55 minutes.
You know, I think that is important for the audience to know. You have done everything percutaneous.
Yes.
And you have fixed the artery with the per-close.
Yes.
Some people go and access the artery surgically.
Yeah, cut down on the groin.
So you don't do an arteriotomy on the groin? It's only the per-close? So how is it, so like the per-close procedure, or the per-close device, how does it look like?
So it's a suture closure system. Basically, once you get the access, then you place you take out your 6 French sheath, then you place the per-close closure device on the wire, and you take out the wire. So the sutures get deployed in the artery first, and then there are 2 needles which bring the sutures from inside the artery or outside the artery. They're already knots are already placed on the per-close closure system. So once you are done with the procedure, you just have to tie, like the knots are already tied. You just pull the knots together.
That's because of Virk is very good. He handled that. That was great.
No, sorry. But she did well post procedure from vascular surgery standpoint. She had other injuries and she finally got extubated. Orthopedics took care of the other trauma. We did get a follow-up CTA. Usually plan is to get a CTA in a month. That she was already in the hospital. She had some seizure activity, which we didn't knew like what exactly was happening. So I was like, let's scan, make sure the stent graft is okay. So this is the follow-up CT scan. She has more pleural effusions on both sides now. You can see subclavian, left carotid, innominate, coming down, the stent graft, descending aorta. So injury is excluded. So this is the left subclavian, stent graft excluding the injury. No evidence of any endoleak and no evidence of any other proximal or distal intimal flaps on this image.
We're very fortunate to have here Dr. Griffith. What are your thoughts about this stents and everything?
Overwhelmed. I think these relatively non-invasive procedures are tremendous. And lumbar vessels and the thoracic vessels and the spine. Tell us about that.
That's a good question. So usually it depends on like how much aortic coverage you're doing. If you're covering almost all the descending aorta, then the risk of paraplegia goes higher. And the other important artery is the artery of Adamiquus. That comes from, it has a variable course, but it comes from T8 to L2. So we usually, sometimes we have to make sure we do not cover that. But with like 10 to 15 centimeter coverage, the risk of paraplegia is very less. And usually the other thing with sometimes you can get an endoleak from a big intercostal arteries. Usually they are very small because there's no like any stenotic lesion or no atherosclerotic disease in the aorta itself. So it all depends on how much aorta you're covering. Risk of paraplegia goes high if you're covering more than 20 centimeter aorta. Risk of paraplegia goes high if you're covering the subclavian artery, because the vertebral artery comes from the subclavian artery. That gives the anterior spinal artery. If your hypogastrics are already occluded, then the risk of paraplegia is high. Or if you already have a infrarenal abdominal aortic aneurysm repair done, the risk, because they're already intercostals or lumbar vessels covered, the risk of paraplegia in those cases go high. So you have to be very careful. If the left vertebral artery is dominant and you're planning to cover the subclavian, then you do a carotid subclavian bypass and then do the TEVA. But in emergent cases, in case you have to, if there's a trauma case like this, you fix the aorta first and then you take care of the subclavian. You can do it after the procedure if the patient is stable. But the SVS, Society for Vascular Surgery guidelines say you always revascularize the subclavian if it is an elective case. Always do a carotid subclavian bypass and then do the TEVA. So this is the case number 2. So both the cases were done on the same day. So it was a busy week for aortic cases. So this is a 58-year-old gentleman, multiple medical problems, coronary artery disease, had stents also, AFib, pacemaker, on Coumadin. So he has everything which like a typical peripheral vascular disease patient or vasculopath has. But unfortunately, he had an MVC, and then he had some forehead laceration, injury to the right lower extremity, but he was stable with a GCS of 15 on arrival to our ER. The echo performed showed a very decreased EF of 10 to 15%, and some apical wall motion abnormality. He did had descending aortic injury as well. His troponins were elevated, but that we attributed because of the cardiac contusion from trauma. The troponins can be elevated. But my concern in this case was with decreased EF of 10 to 15%, it will be extremely difficult to be under general anesthesia, risk of any cardiac event, stroke, and is higher in this gentleman with multiple comorbidities. So we did call cardiology for pre-op evaluation because he was hemodynamically stable. So cardiology said he is cleared from cardiology standpoint. So this is the CT scan. So importantly in this case, so when we do the TVARs, so you always plan like where the arch vessels are coming from, and does the patient has any aberrant anatomy or any other anatomical variants. So in this case, this is the left carotid, this is the left vertebral artery that's coming from the aortic arch, and this is the left subclavian. So looking at this, I was like, okay, so we have some room in case we have to cover left subclavian, we'll cover it in case it is needed. Because the left vert is coming from the aortic arch, usually it happens in around less than 1%, around 1% patients have a left vertebral artery that comes from the aortic arch. You can see some peri-aortic hematoma as well coming down to the descending aorta. See some peri-aortic hematoma. And this is the injury here, aortic transection. Almost looked like a pseudoaneurysm on this axial CT. Aortic injury, the left subclavian, there was a questionable lesion, looked like some plaque that has shifted like at just beyond the left subclavian artery with the aortic injury distal to the subclavian artery. So this case I did discuss with cardiology and with trauma team and with the patient, patient and the patient family. That is, he's extremely high risk because we have to have good control when we deploy the stent graft. We have to make sure the patient holds the breath, so we have a good, like we land it like exactly where we want to, because we don't want to land it like on the subclavian or the innominate. But given the injury and given his comorbidities, we decided to perform the procedure under local anesthesia. So again, the same steps, right common femoral artery access, 2 closed closure devices, and then we performed the TVAR. The operating room time was 60 minutes. And this is the completion angio, which demonstrates the innominate, the carotid. You can see the vertebral artery from the aortic arch and the subclavian. It was extremely difficult because first of all, he was not under general anesthesia, moving a lot, not like we asked him to hold his breath, so but he was not very cooperative. But I didn't want him to put to sleep, so I said, well, I think so we can do this percutaneous. And then the pacemaker was really in the way. This is an angiogram done like at a very angle shot, but when we deployed to get to the arch, like to open up the arch, the pacemaker was right on the subclavian. So it was extremely difficult to evaluate where we're going to land the stent graft. We did use IVUS also to get the exact landmark. Then we deployed the stent graft. But in this stent graft, the open part of the stent graft, as the struts are partially on the subclavian artery. but the subclavian artery is getting filled. But a good seal and good proximal seal, a good distal, no endoleak on this angiogram. We did obtain a follow-up CTA on this patient, and that demonstrated all the arch vessels were filling. The left subclavian was also filling, but there was a partial coverage of the open part of the stent graft on the subclavian, with no evidence of endoleak and successful exclusion of the injury. So this was my first local anesthetic percutaneous repair. And he did okay. Guess he is discharged home now. Any questions on this case?
What did you do if you had an endoleak at the time of the procedure?
So it all depends what kind of endoleak it is. Again, we did not post-dilate this stent graft because of the aortic injury. So if it's a type 1 endoleak, the type 1 endoleak is...
Would you please refresh our minds about the type of endoleak?
Yes, sir. So there are total 5 types of endoleak. So type 1A is if it leaks around the proximal landing zone. Type 1B is if it leaks around the distal landing zone. Type 2 is if there is any intercostal arteries or lumbar arteries or IMA below. That's like feeding if it's an aneurysm or it's leaking around. So that's a type 2 endoleak. Type 3 endoleak is, so this is a one-piece case. One-piece case means you just deployed one 10-centimeter stent graft. If you're using the multiple stents, if you're bridging, like if you're overlapping 2 stents, if it leaks in between those stents, so that's a type 3 endoleak. Type 4 endoleak usually does not happen nowadays. It is because of the porosity of the stent graft material. But nowadays, like they're very well advanced, and we usually don't see type 4 endoleaks anymore. And type 5 endoleak is the sac endotension, in which usually happens in aneurysmal cases. And if you're not able to identify it, whether it's type 1, type 2, and still the sac is increasing in size, then you label it as a type 5 endoleak. So type 1A endoleak can be fixed by putting another cuff, extending it, but it all depends like how your arch vessels are here. You might have to do a carotid subclavian or carotid bypass or a debranching from the ascending aorta to get the coverage. The other thing is their endo screws have come up recently, so you can go percutaneous again, and so basically it's like Medtronic company. They have Aptus screws, so you screw the stent graft into the aortic wall to close the type 1 endoleak. You can get into that. You can coil the proximal side with coils if you can. So these are the measures you can fix the type with the cuff, with the anchors, endo anchors, or coils. The same with type 1B. Type 2, you can do coil embolization of the IMA, intercostal, but extremely difficult. Sometimes if it's for an aneurysmal case, most of the type 2, I would say, they resolve on the following CT scans, because during the case the patient is heparinized, fully anticoagulated, you'll see some endoleak, but most of the time type 2 endoleak resolves. Only time you intervene is when the sac is increasing, the aneurysm size is increasing, and the patient is symptomatic. So how we fix type 2 endoleaks is by coil embolization, or you can directly go into the sac and inject glue or onyx to obliterate that space, and sometimes you can go through the sac and coil embolize the feeding vessels. Type 3 is you put another, you realign the stents. For example, there are 2 pieces which are leaking, so you try to realign the stent and put another stent graft or do open. Type 4, again, same, you bridge it with another stent graft, it happens. And type 5, you're not able to identify. If you're able to identify, like what if it's like leading, coming from the lumbars or the IMA, you can coil embolize. Otherwise, you do an open repair of that.
How often do you follow these patients with imaging?
Okay.
Do you order CT angio every once in a while, or how often?
So basically, after the procedure, CTA in 1 month, and then CTA every year if it's stable. For abdominal aortic aneurysms, sometimes if the first or the second CT scan is stable, then I go with the ultrasound just to look at the sag. So I'll skip one CT in between, and depending upon what the creatinine of the patient is, if it's high or no. Or like if the patient has a CKD disease, follow with the ultrasound. So usually it's 1 month CT scan and then yearly thereafter. So next patient, so this is the third case. So we were supposed to do this case also on the same day, but anesthesia will not. They said we cannot do this case. Patient would not lie flat on the table. So anyways, we canceled this case that day. So 68-year-old female, she presented initially to the outside hospital with the substernal pain, lower back pain, some nausea and weakness. She was transferred to UH as her troponins were also elevated. When she came to the hospital here, they did a CT scan with they were concerned of PE also, and the CT scan for the PE was negative, but they found penetrating aortic ulceration on the descending aorta. She was on the medicine service, but the concern was penetrating aortic ulcer and what to do about, do we need to fix this or shall we just follow this along? Subsequently, while she was in the hospital, she was on 7 liters oxygen, very short of breath, was not able to lie flat. They started diuresing her, creatinine also bumped, nephrology was consulted. So multiple medical problems in this case also. So chronic kidney disease, AKI on the top, and then respiratory failure. While she was in the hospital, she had a few episodes of shortness of breath, tachycardia, and then they got a VQ scan, which was positive for PE at this time. So another concern was like medicine was like we cannot anticoagulate because of the penetrating aortic ulcers, and because she has a PE, so she needs to be anticoagulated. But we did start the patient on heparin drip that time because I don't think so it increases the chances of any like aortic rupture given the penetrating aortic ulcers if it's done for a short period of time. Anyways, the reason we operate on penetrating, not all the penetrating aortic ulcers needs to be fixed because the procedures are not benign at all. These procedures, they look simple, but there are a lot of risk complications involved in the procedure itself, during the procedure and post-procedure as well. And down the line, like we don't know how the stent graft is going to behave like another 10 years. The aorta is going to get dilated, aorta is going to get penetrating ulcers like if the patient has atherosclerotic disease. The reason we elected to proceed with the stent graft in this patient was to look at the penetrating aortic ulcer. It had almost like an intramural hematoma kind of picture, and the penetrating aortic ulcer, one of them was extremely large, very worrisome for rupture. And on the other hand side, if you read literature on penetrating aortic ulcers, is if it's a large penetrating aortic ulcer, then it can lead to dissection. So it's recommended that the large PAUs should be fixed to prevent any acute dissections in the future. So these are some of the images. This is the small penetrating aortic ulcer. This is definitely a large one with some hematoma around it. An axial CT scan. Reformat image. This is the center line penetrating aortic ulcer, proximal and distal. So this is way beyond the subclavian, so we're not concerned about that. The concern is, shall we just cover this? So this can be done in a 10 centimeter with a 10 centimeter stent graft. If we exclude both, then we need a 15 centimeter stent graft. Then we end up like, oh, are we covering too much aorta? Are we causing any risk to the blood supply of the spinal cord? But given her subclavian was open, we're not touching the vertebral artery. The hypogastric arteries are open. There's no prior EVAR done, so the like lumbars, everything is okay. And the stent graft, as we were talking earlier, beyond 20 centimeter, then the risk of paraplegia goes higher. So we did explain all the risk benefits to the patient and the family, and we elected to proceed with the stent graft in this case. Again, so she is a morbidly obese patient. Again, not a good general anesthetic candidate, has a PE, and has been on home oxygen for a while. The concern was in case we intubate her, she won't be able to come off the ventilator. So we elected to proceed with percutaneous and local anesthetic in this case as well. So we did a percutaneous exclusion of the penetrating aortic ulcer. We did use just local anesthesia, again 2 perclose devices, and total operating room time was 55 minutes in this case. So she did well. Our plan is to scan her in a month. And her creatinine was elevated as well. So we just used IVUS to see where we're going to land it, and then we did a completion angio. So we used total of 15 ml of contrast in the case. Any questions about this case?
I use is known as the ice catheter. This is the round iris. This is what cardiology and vascular use. It's a round iris. It gives you a whole round image of the wall of the vessel. So you get it's very well to see the stenosis. Like in cardiac, sometimes when they cover with stents, they're not sure whether they're really covered the area of stenosis. So this iris is a different iris from what you see. This is a much smaller caliber, comes in different sizes. If you see, it's a round
360.
It's a 360, yeah. So this is the volcano.
Let me see if I can.
Assuming the percent of these cases that have ulcerations that are penetrating are almost all arteriosclerotic instead of vasculitis, bacteriovasculitis. Do you see that?
Yes, sir. It's mostly atherosclerotic.
The biggest work they've done on this is actually from the University of Michigan. So way back in 13, University of Michigan was one of the biggest centers. They were doing it for penetrating ulcers, and there was a big debate going on that whether should penetrating ulcers ever be treated by endovascular. And they had done something about 200 cases. And those times it was considered more like if it's like a big ulcer like this, or if the patient was really symptomatic. If they were complaining of really bad pain, they would treat it just like a dissection. They would treat the penetrating ulcer.
So briefly talk about, so we have seen a couple of cases of aortic transection, we'll discuss the pathophysiology, mechanism of injury, and delayed versus emergent operation for the aortic transection. So this image from the Gray's Anatomy book. So ascending aorta, arch of aorta. So ascending aorta is basically, it is very mobile. It's not fixed structure at all. This is unfixed. It's mobile. But the descending aorta is relatively immobile due to intercostal arteries as well as ligamentum arteriosum. So when you get like high motor vehicle collision with rapid deceleration, most of the time the injury happens at the isthmus, the ligamentum arteriosum, because the aorta is relatively immobile and fixed. Looking at the blunt aortic injuries, the majority are from motor vehicle collisions. This is the second leading cause of death after head injury between age 4 and 34. So overall, the percentage is very low, but it's very lethal injury. Approximately 20% of the patients with blunt aortic injuries survive long enough. So 80% almost, they do not present to the hospital also with this kind of injury. If they ever present to the hospital, they are relatively stable. So the incidence from blunt thoracic injury is 1.5 to 2%. They had a multi-center study done with 274 cases. Again, 81% was from automobile accidents, the motorcycle collisions, aircraft crash, and the other significant thing is any significant fall from the height. Again, it's same mechanism, rapid deceleration. The aorta is very fixed at the ligamentum arteriosum at the isthmus, so you get injury at that level. So most of these patients, they have associated injuries. They have sometimes severe head injury, intracranial bleeds, some lung contusions, rib fractures, cardiac contusion. As we saw in one of our patients, the troponins were elevated. They can have some intra-abdominal hemorrhage, some long bone fractures, pelvic fractures, and the other significant thing is whenever you have a thoracic aortic injury, always look for if there's any diaphragmatic rupture, any blunt diaphragmatic rupture. So you have to be very careful when you evaluate these patients with the other associated injuries. If the patient does come to the hospital with aortic injury and you have any other associated injury, so the patient is relatively stable. So the other injuries can be taken care of if you can wait on the aorta. That's what we did on one of our cases here. So the pathophysiology is, as we talked about, most common site is the aortic isthmus, just distal to the left subclavian. Why that is important? Because it's a transition zone between the more mobile ascending aorta and more fixed descending aorta, and it allows a lot of stretching with rapid deceleration. And the other thought process is that isthmus is intrinsically weak from the remainder of the aorta. They have done some animal studies in which they have looked at the elastin levels at the isthmus versus the remainder of the aorta. But there are no human studies that have never been done. Arch here, left subclavian artery. We'll talk about a couple of mechanism why the incidence of injury is high at the level of isthmus. One is the water hammer effect. What happens when the injury, there is a compression of the abdomen due to sudden impact and it occludes the aorta, the sudden impact, and it leads to rupture of the proximal weak isthmus. So that's one mechanism. It's called as water hammer effect. The other one is the osseous pitch theory. So aorta, if you see, it's trapped between the sternum and first rib, medial clavicle, then sternum, and then the vertebral column. And whenever it's a impact, so there's a lot of bony structures and a lot of shearing, stretching that can cause to focal rupture at the level of the isthmus. So usually the patients, they present with chest pain, some intrascapular pain, or difficulty breathing or swallowing. Usually they are found out, most of the patients with the trauma, they get pan scans when they come to the ER. On physical examination, you can see some seat belt imprints, some steering wheel impact, or whenever you get a call from the scene that's a high-speed motor vehicle collision, rapid deceleration, so you should start thinking, oh, maybe has some thoracic aortic injury on that. Sometimes they can get upper extremity hypertension, but you have to check pressure in both the arms and both the legs as well, because that injury can create like a pseudo coarctation, and the pressure in the upper extremity will be higher as compared to the lower. And then obviously you check the femoral pulse if there is any deficit from rupture or any dissection that has happened further from the aortic injury. So this is the chest X-ray. So usually the chest X-ray will demonstrate widened mediastinum, as you can see on this X-ray, and usually it gives us indication that the patient likely has a thoracic aortic injury, but there are other several reasons why the patient can have a widened mediastinum. So again, as we discussed, the supine chest X-ray greater than 8 centimeter, we call it wide mediastinum. Upright should be 6 centimeters. So 6 and 8 are the numbers to be remembered. Then it can be from the enlarged aortic knob. It can be from left apical cap, that's the pleural blood above the apex of left lung. From large left hemothorax, you can get mediastinal widening, or displacement of the left main stem bronchus, or you can see deviation of the NG tube rightwards, deviation of the trachea, and the wide left paravertebral stripe on the X-ray. So the imaging modality, as we discussed, obviously the chest X-ray, and then you decide if the patient is stable or unstable. The chest X-ray and the patient is totally unstable, like it's very hypertensive, not responding to fluids. The options are to explore the patient and see if patient has it, and you can fix at that time. The other modality is the transesophageal echogram. If the patient is relatively okay but a little bit unstable, to go to the CT scanner. So this can be done at the bedside. So TEE can be done at the bedside. It is fast, but it all depends. When you call cardiology, they can come and do it. So I think that's the rate limiting step in our hospital. So TEE with on bedside is relatively fast, but it's operator dependent. Sometimes body habitus of the patient also, and if the patients are intubated or not intubated. But if the patient cannot go for a CT scan, then would prefer to get a TEE. You can see the intimal flap, you can see the dissection, you can see like a local rupture, contained rupture. Then obviously the CTA, nowadays this is a gold standard to diagnose the thoracic aortic injury. Then comes the aortogram. So aortogram per se does not take time to do a aortogram. Getting everything set up is a big deal. And the other thing is it's invasive procedure, and sometimes you can miss localized injury on the angiogram rather than the CT scan. So this was a paper from Annals of Surgery, in which in this study they had 494 patients, 71 had blunt thoracic aortic injury, and the sensitivity of the CT scan approached 100% and 92% on the aortogram. So you can, so it's a prospective study. It's not a level 1 evidence, but definitely the CT sensitivity was 100% and 92% on the aortogram. So what can you see on the CT scan? You can see an intimal flap, you can see a periaortic hematoma, you can see a luminal filling defect, aortic contour abnormality, pseudoaneurysm, any contained rupture or vessel wall disruption, or if there is any active extravasation from the aorta. So there are a lot of things you can look at the CT scan, and so the other imaging modality is MRI. So you can make a point. So CT has radiation. Say we have to give contrast for CT scan. Why not we get MRI? But it takes more time for image acquisition. It's cumbersome, takes a lot of time, cannot be done. Sometimes these injured patients, they have metallic objects, and we don't know like whether the patient has something which can interfere with the MRI machine. So it's safer to get a CT scan in case you're concerned about the thoracic aortic injury. So coming to the management of these patients, so once this patient arrives in the trauma bay, so basically the management goes with.
Can I ask a question about the MRI?
Sure.
Would you use MRI for evaluation of endoleaks for growing aneurysmal sacs? Does that help you?
Definitely. If the patient has still the CT is a little bit more, CT with contrast is extremely helpful in case you're evaluating for endoleak. But if the patient has chronic kidney disease, creatinine is elevated, then usually go with the MRA to identify any. So it's going to give us, like, if the sac is increased in size, we might not be able to localize where exactly the endoleak is coming from. Yeah. Or maybe Dr. Huja can comment a little bit more on that.
Find out what is right. So majority of time when looking at these are not type 1, right? Type 1 actually happens in the room when you're doing the procedure. Type 1 will not survive for so long. So it's either it's normally a type 2 endoleak. So 5 is basic endotension, nobody knows how to convert this grading size. So 2 is what you really think you can treat. And 2 also you can watch, it's nothing that will be treated like tomorrow. So you want to see what vessels, where is enhancement actually happening in the sac, so that you can actually find out how to treat it, right? If it's a collateral vessel, it's a lumbar coming there, it's an IMA coming there, or is it something that you need to percutaneously access? So as you were saying, when you access it, the sac percutaneously, there are ways that you can actually just access the sac, measure the pressure, and then keep injecting on it. But that will be like you injecting like couple of, it's a very expensive treatment, right? But you're not treating the actual culprit. The best way is you need to know exactly where the enhancement was, so that you can target the area of enhancement and see if you can catheterize that vessel. So that's why the CT is very, very helpful.
Yeah.
But majority of everybody does is, once they become confident that it is nothing that's going to rupture, you can always alternate between CT and ultrasound just to cut down the dose. And remember, in these CTs, you also want to have everything. You want to have a non-contrast, you want to have a contrast, and you want to have a delay. If you don't have a non-contrast, sometimes the calcifications, the intimal calcifications in there, they just look like they are contrast, right? So until there is a non-contrast, you cannot differentiate whether the sac increase is happening, and is this actually really contrast, or is this just calcification? And then you need to see a delay also that tells you that exactly is that contrast, like just like a bleed that you see, it becomes bigger. So then you can target that area. So CT is definitely far more resolution, far more specific for finding endoleaks, but if you can't, then you MR. Okay. They tell you the sac is becoming bigger, but why and how to treat it.
Thank you.
So management in the trauma bay goes with the ATLS protocol again, ABC, airway, breathing, circulation. You have to have 2 large bore IVs for medication and fluid. So the initial treatment for these patients, so as we know, 80% of the patients do not make to the hospital. 20% patient make to the hospital, but they are stable, so they're not going to die in the trauma bay. But you have to evaluate other associated injuries with these cases, especially bleeding pelvic fracture. So if you're doing a TEVAR and the patient has a bleeding pelvic fracture, you're giving heparin, more heparin, you're adding more anticoagulation. So you're not helping the patient. So you have to see what other injuries are and what is the urgency to repair the thoracic aorta. So basically, the initial management is impulse control. That's the negative inotropic support to control their blood pressure. put them on a beta blocker, esmolol drip. It's a short acting. Keep the blood pressure around 100 and 110, heart rate around like 70s, and this will reduce the risk of further extending the injury, that's the intimal or media, or if it's in the adventitial plane, and potentially reduce the volume of blood loss also if it ruptures. So this was from Journal of Vascular Surgery from 2011. So they looked at it prior to the use of antihypertensive therapy for blunt aortic injury. So there are 12% of hemodynamically stable patients awaiting surgical repair. So this was a prospective study. So this was the mortality was 12%. 71 patients awaiting repair were treated to manage their heart rate and blood pressure with a goal of blood pressure 100 and less than 100 beats per minute. But none of the patients had aortic rupture while waiting for repair. And there was no mortality in those cases who were initially treated with medical management. Looking at the grading of blunt aortic injury, so usually it happens at the level of aortic at the isthmus. So grade 1 is intimal tear or a flap. Grade 2, you get intramural hematoma. Grade 3, you have a pseudoaneurysm, which one of our case demonstrated. And grade 4 is frank rupture. So 4 grades: intimal tear, intramural hematoma, pseudoaneurysm, and frank rupture. So the management of these patients, initial as we talked about, is blood pressure control. Unstable patient, go to the OR for exploration. Hemodynamically stable. If they have type 1 injury, so it's a non-operative management, blood pressure control, antiplatelets, and serial imaging. So you scan them in a month, then probably 3 months to see how the injury is behaving, if it's healing up or not. Type 2 to 4, as we talked about, delayed repair, endovascular, if the patient has a favorable anatomy. Favorable anatomy, you have to see like how far it's from the subclavian, what is the diameter of the thoracic aorta, what does the access vessel looks like, because you're putting a big 20 to 22 French sheath in the femoral arteries. If the femoral arteries are calcified, or the patient has aortoiliac occlusive disease in which you won't be able to put a stent graft, so that's going to be a problem. So minimal calcification, if it's just a focal aortic lesion, because you do not want to cover the whole aorta with the stent graft, because the risk of paraplegia is going to go higher. There should not be any significant tortuosity of the thoracic aorta, minimal or no intraluminal thrombus. So and then this was a paper from Eastern Association of Surgery for Trauma. They looked at immediate versus delayed repair of the thoracic injury. So they had 7 comparative studies, some exclusive open surgical repair, others were both open or endo repair. So the pool risk for the death and paraplegia were significantly higher for early compared with the delayed surgical repair. So the reason being because they had other associated injuries as well, which we were not looked upon during, like they thought like, oh, has a thoracic aortic injury, needs to be fixed before fixing the pelvic fracture or fixing any other associated injuries. So the death, the risk ratio was 2.07, paraplegia was 5.9. Again, this is a paper from delayed repair for blunt thoracic aortic injury. Is it really equivalent to early repair? From Journal of Trauma. They had 481 patients, 78 from institutional review, and 403 they identified from the National Trauma Data Bank. They looked at the mortality in early open surgical repair, 20 versus 9% in the institutional review. 22 versus 14% in the National Trauma Data Bank. So 20 in early and 9 in the late. and then 22 in the early in the National Data Bank, and 14 in the late. And the chest injury score was significantly higher for those who underwent early repair, whereas the orthopedic injuries were far more common who underwent a delayed repair. So then the American Association for Surgery of Trauma, they have two studies. So they compared the, so they have AAST1 study and AAST2 studies. They compare the diagnosis and treatment of blunt thoracic aortic injuries. The mean time from the injury to the aortic repair has increased from 16.5 to 54.6 hours. So delayed repair is helpful, is beneficial to the patient if the patient is stable. And overall mortality related to blunt thoracic aortic injury has decreased from 22 to 13%, because nowadays we are focusing definitely on the thoracic injury, but other associated injuries as well, stabilizing the patient more, controlling the blood pressure more, and then performing the procedure. AST1 was open repair. AST, 65% of the patient underwent endovascular repair. So the caveat in this study was, so you can make a point that the AST1 study all had open surgeries. So the risk complications of the mortality is going to be high in that. So that's the downside of this study. But they do looked at the mortality related to the thoracic endovascular repair in the AST2 study. That was 7.2%. Thank you.